Welcome to this PCR webinar on PFO closure in 2021. We're going to discuss the groundbreaking 5 years data from the REDUCE trial, but also other indication for PFO closure. So again, the learning objective of this webinar will be to discuss the evidence for PFO closure in patients with cryptogenic stroke, and also to understand the workup and how to refer these patients for treatment, and also again learn about other indication for PFO closure. My name is Lars Sondergaard. I'm a cardiologist based in Copenhagen in Denmark. It's my pleasure to be joined today by David Hildyk-Smith, who's also a cardiologist based in Brighton, UK, and John Wolpe, who is a neurologist from Houston in Texas, the US. So before we start, I can shortly tell about the background for PFO closure, because this concept is more than 20 years old. And in the beginning, it was argued that PFO was at least twice as prevalent in patients who had suffered a cryptogenic stroke compared to the general population. And also there was observational data suggesting that closing the PFO would reduce the risk of a recurrent stroke. However, the first 3 randomized trials we saw, the CLOSURE 1, the PC trial, and the RESPECT trial, all came out negative. They didn't show any significant reduction in stroke risk in their primary ITT analysis. But then in 2017, we saw 3 simultaneously publications in New England Journal of Medicine, all showing positive outcome of PFO closure. Again, it was the RESPECT trial, which was first not positive, but with extended follow-up, it actually turned out to be positive. Then we saw the REDUCE trial, and finally the CLOSE trial, all paving the way for PFO closure in these patients. So the conclusion from this trial was that in carefully selected patients with cryptogenic stroke, PFO closure significantly reduced the risk of a recurrent stroke and also new brain infarction as measured by MRI scan. And also there's a low risk of device and procedure-related complication. And I think it's fair to say that these trials changed the guidelines and also clinical practice around the world. So the agenda for today will be that we're going to discuss now the 5 years outcome from the REDUCE trial. We're going to discuss how to select patient for PFO closure. There will be discussion on PFO and atrial fibrillation, and maybe also should we consider to treat some patient which was not part of these trials, changing the guidelines. And then finally, other indication for PFO closure, particularly on the migraine side. So we want this webinar to be as interactive as possible. So please use the chat function, and we will try during the webinar to answer your questions or address your comments you may have during the presentation. So with that, again, welcome, John. Welcome, Dave. I hope we're going to facilitate a good discussion here among the attendees. So John, why don't we start with you, and you can maybe talk about the REDUCE trial, what was the initial outcome, and also now with the 5 years outcome.
Yeah, thank you, Dr. Sondergaard. Thank you, Dr. Hildyk-Smith, for having me, and thank you to the cardiology attendees. It's nice to be here as a neurologist in front of cardiologists. Usually when a neurologist is called by cardiologists, it's a poor prognostic indicator. So it's nice to be here under more pleasant circumstances. I do welcome all the questions from the presentation as we go. So as Dr. Sondergaard mentioned, there was a real revolution in 2017 in how we viewed PFO treatment in stroke. And I'll just add to that most of our secondary stroke prevention opportunities such as antiplatelets and lipid management carry relative risk reductions on the order of 20 to 30%. And so when we saw in the reduced trial, 75% relative risk reduction and similar across other studies, this was a major opportunity for us. The other studies that were done around that time or between 2017 and now had to do with questioning whether there are medical management options that are separate from antiplatelet, specifically investigating the direct oral anticoagulants. And one can choose a few different studies, but overall, they were negative trials in the sense that aspirin was equally efficacious to the direct oral anticoagulants for these embolic strokes of unknown source, or even the subgroups of the PFO patients. Taken together with the positive device trials and the neutral oral anticoagulant studies, it led to our society, the American Academy of Neurology, updating their practice advisory, and in part, it read that in the properly selected patients under 60 with a PFO, an embolic appearing infarct, and no other mechanism, clinicians may recommend closure after discussing the risks and benefits. The reduced trial was published with a mean follow-up of 3.2 years and a primary endpoint of 24 months. However, the study continued to follow patients beyond that, and that gave us the opportunity to update the results with a 5-year result. So this was the reduced 5-year data. Primary endpoint remained the same, the freedom from recurrent clinical ischemic stroke and the incidence of new brain infarct. The studies had the same 664 subjects, and I'll just highlight that it was a 2-to-1 randomization. So as we look at the results, as we look at these tables, keep in mind that the subjects were randomized in favor of device 2-to-1, meaning the medical management arm was smaller. And with our colleagues across the globe, the study was completed and just reported in the New England Journal in March. These were the clinical assessments. They were done every 6 months for the first 2 years, and then annually up to 5 years. And an MRI brain was obtained at baseline and 24 months. There was not an MRI obtained at 5 years, and bubble studies were performed at baseline 1 and 2 years. So one result we found at the 5-year data was that once there was a positive study, once we had a device management that was proven, patients within the medical management arm opted to cross over. And that was an 11% crossover within the study. And that diluted, again, the antiplatelet group a bit in terms of its statistical power. And then there were some patients who discontinued the study and were no longer kept within the data set. The table 1 here is shown, and it's fairly consistent across risk factors and demographics. I won't go into much detail about that unless there's a question. But this was the somewhat interesting result, was that we did see this hazard ratio look very similar to the reduced 2-year primary endpoint. That hazard ratio was 0.25, and in 5 years was 0.31. Remained highly statistically significant, and event rates remained significantly less in the closure group. What was observed, though, is that the separation between the two groups occurred primarily within the primary endpoint timeframe of 2 years, and that beyond those 2 years, there was relative stability between the groups. Why is this? Other studies, such as the RESPECT 10-year study, which was mentioned earlier, observed ongoing events in the medical management arm. So it remains, one study showing ongoing events in medical management, and this study showing stability. Why is that? It may be because of the crossover between the device group and the medical management group. It could be that the device was stable in a patient population that had better compliance with antiplatelet therapy, and we'll have to continue to look into that. Looking at another way of digesting the data is to see the subgroup analysis, and for the most part, subgroups were similar. I'll just point out one that I think is of particular importance as we continue to study this disease, and that's the age effect. If anything, we saw the older patients having an amplified benefit. When we consider PFO and stroke, there's a tendency to refer to this as a stroke in the young. And while we're not, defining what young is here, I would simply say that this is clearly an age effect in which other factors, such as maybe thromboembolism risks increasing, begin to creep in middle age, and that seems to contribute to stroke risk. So we should absolutely be considering our middle age population. With that in mind, I would like to go through a case, and I will welcome any input or questions. So this was a patient of mine who came to me last fall in November of 2020 with acute stroke symptoms, left-sided weakness, received thrombolysis, and clinically had a complete resolution, did well, had a full recovery. During our evaluation, we do MRI that can differentiate between new and old stroke. New stroke is detected on diffusion weighted or DWI imaging, and any old stroke would be on FLAIR imaging. So I'll show that in just a moment, but I'll tell you there was no large vessel disease, and the echocardiogram was normal other than the presence of a PFO. So on that DWI image, this is the residual of the event that clinically resolved, but we can still see that there was ischemia. There was a small infarct in the right temporal lobe. But then in looking at that FLAIR imaging for anything else that had happened in this patient's life, we see interestingly one other small cortical embolic appearing an infarct in the right cerebellum. And then overall, his FLAIR imaging looks very normal. So this gives us a clue that this is not an atherosclerotic patient. This is not a patient that's accruing an abundance of small vessel disease. So he doesn't have vascular risk factors of hypertension, diabetes. He's not a smoker. And we can call those cortical strokes, take his age, and together put them into a ROPE score. The ROPE score is a risk of paradoxical embolism. It's widely available online on MedCalc if you wish to take a look. And it provides two outputs. The first output is what is the likelihood that this PFO is pathogenic versus incidental? And in this patient, he scored 66% likely that it's pathogenic, that this stroke was caused by the PFO, meaning more likely than anything else. And it is a 2-year risk in the ROPE score, but if we look at that as an annual risk, it would be 4%. And 4% annual risk of recurrent stroke is almost identical to what was observed in the 2-year follow-up of the medical management group of the reduced trial. So in this case, we're seeing a patient who would have been outside the age range for the study, but very much looks like the patients that were studied in the reduced trial. And going back to the subgroup analysis, although the analysis ended at 59, it would be interesting to know if it was continued upward to 70, what would our trend have shown? So with that, I'm happy to pause and hear your thoughts on these patients who are middle-aged and in the 60 and up group.
Thank you, John. That was a great overview of the data from the reduced trial. So the case you showed here at the end, a 65-year-old male, he was certainly a patient who was not included in the trials we saw and the trials which changed the guidelines. And also, you briefly showed the American guidelines also talking about patients younger than 60 years of age. So how is the situation in the US now? Is a PFO closure in a patient of age 65, is that reimbursed?
Yes, we've been able to get that issue. We've been able to manage it, as you may or may not know. There's probably 1,000 different, insurers, so every situation is a little different. But overall, understanding that you can even look at the economics of PFO closure, and that's what the insurers and different those who pay for these procedures would look at. And we did publish that the savings from PFO closure, the savings of preventing stroke and disability, and allowing the patient to continue being, active in their own economic input was really occurred at 2.5 years. So even though this is a disease in which we, when you do a clinical trial, you say 2 years because that was what we expect, but it showed economically that was almost exactly the same. So from a patient standpoint, a study standpoint, and even an economic standpoint, it's a condition in which we can really think about a relatively short-term horizon for benefit.
So Dave, we're talking about carefully selected patient, and so what about UK? Would you try to tailor it to a specific patient, or will you be very strict about how should I say, the patient who was actually part of the trial?
Yeah, so I mean, we have some guidance which suggests that we should stick to the trial um, criteria for the selection of patients for PFO closure. But in reality, as long as no one's listening to this webinar, there is a little bit of latitude on that. And I think on an individual case basis, we would certainly look at somebody like that and say, well, okay, they do fall slightly outside the criteria for the trial, but fundamentally they're adherent to the philosophy within the trial. And simply because they have an age which is slightly above the cutoff is really irrelevant. You know, the PFO doesn't go away. The risks associated with the PFO don't go away. In fact, some of them, as John has already said, might be expected to magnify with age. So we would look, favorably on somebody like this being presented by our neurology or stroke colleagues as a case for possible PFO closure.
John, there's a question here in the chat function, and please use the chat function if you have questions or comment. So these trials was designed a little bit different. For the reduced trial, it was antiplatelet therapy plus minus PFO closure, and the patient was actually adherent to antiplatelet therapy up to 5 years. Very few patients actually skipped it. What would you recommend a patient who have a PFO closure today? Should they stay on antiplatelet therapy for life, or can they skip it after a couple of months, a year?
Well, thank you for that question because that is exactly what I think our American Academy of Neurology guidelines left off, which is exactly what you point out, that medical management remains relevant after device closure. It was part of the reduced trial, although it was variable in other studies. Medical management continued in the patients who had a device closure. So yes, I think if there's a takeaway from this, it's that there's a combination of risk factors that lead to PFO pathogenicity, and one of those risks is thrombotic potential, and having at least an antiplatelet and potentially a dual antiplatelet for a short time is the way to go.
For a short time.
For that's where, for the dual antiplatelet, I leave it to the cardiologist. There's variability in how everyone feels about endothelialization, but for the long period afterwards, we do look at other factors. If a patient has a risk, has had multiple DVTs or PEs, that would be someone who you might consider something other than an antiplatelet. But for the patient who's more standard, like the studies in which they don't have a hypercoagulable condition, we favor aspirin. Within Reduce, you were asked to kind of stick to one regimen within your center, and we did aspirin.
What are you saying to your patients after closure, Dave, with regards to antiplatelet therapy?
Yes, I mean, of course, one of the things that they like about the idea of closure is the possibility that they might be able to come off the tablets that they're on. They've often been put on a statin, which is in many cases not appropriate for the cause of their stroke. With regards to the aspirin, of course, it depends a little bit on how certain you are that the PFO was what was responsible for the stroke. And if the rope score is high, if your index of suspicion is very high, like a young patient with the Valsalva maneuver and a high risk PFO, and you're sure the PFO was responsible, then really there's no indication for aspirin beyond the period of endothelialization of the device. So we'd be quite happy to stop it after 6 months.
There's also a question here about the delay in diagnosis of PFO. John, it's you as a stroke neurologist who see these patients. Is a proper awareness about PFO in these patients and symptom for workup and eventually for closure? Or how do you see that involving?
Yeah, I think that their patients may be delayed because their stroke syndrome may have been a TIA or something, and they didn't come to neurology attention, or they may be delayed because the initial screening test, whatever modality was picked, may have had a technical issue or may have been communicated as a trivial finding. We know, and I won't speak to the cardiology technical factors, but we know that those factors may influence how positive a bubble study is, or whether or not it's even positive, and that can sometimes lead to delay in diagnosis. Interestingly, we are doing a post-approval study, so beyond the reduce pivotal trial, a post-approval study, and recognizing that we're expanding the enrollment period to over 400 days. So for these patients who uh, may have been in a situation where they couldn't get PFO closure, they weren't detected, they were uh, bouncing around from one opinion to the other for a year, they would be very appropriate for PFO closure, in our opinion.
John, there's also a question here about when to do the PFO closure in such a patient.
Right. I think once
As
it's
early as
diagnosed,
possible, or should you wait?
yeah, no, I think as early as possible. I think once one finds the etiology, then the only other discussion to have is with the cardiologist about the risks and to understand that it's right for the patient. But once we make the diagnosis, we recommend closure.
Hmm.
In fact, that was you alluded to the RESPECT trial not meeting its intention to treat. That was a major reason why, was because of the delay from diagnosis to procedure. Was patients had of strokes, and you don't want to have that occur.
Yeah. I mean, you mentioned the rope score. There's a question here. What's going into the rope score? How do you estimate the risk in these patients?
Yeah, so basically, it's your typical risk factors: diabetes, hypertension, smoking, and you get points for not having those. So it's kind of a negative. Uh, if you don't have those, you get points, and then your age is also gives you points. The younger you are, the more points you get, and it's a 10-point scale. And anything between 6 and 10 would be more likely than not the PFO is the cause, and anything 3 to 5, it's indeterminate. It's one of those patients where you have probably a 30 to 38%, I think, is the range, where you really have to look closely at that patient whether or not there were other etiologies. And in the 0 to 3, they're almost certainly not the PFO is a cause.
Yeah. So I think that was a good discussion, John. I know you got one more case. Maybe we could have a look on that. And
Sure. So we previously discussed a patient who was, middle-aged and didn't necessarily have that stroke in the young evaluation that we would normally think of. This is the opposite. This is a classic patient that is a young 23-year-old female. And I'll just mention a very healthy female. This was a woman who was a college athlete, very intelligent, going to medical school. And she was found initially in our evaluation with seizures, which had not been there early in life. She started having seizures in her 20s, and during our evaluation, we found two strokes: one in the left basal ganglia and one in the left temporal lobe. The one in the left temporal lobe explained why she was having seizures now, but they weren't classic embolic appearing like the cortical strokes. And interestingly, she'd even had two retinal ischemic events. So we did our typical neurology workup. We looked for demyelination, we looked for inflammation, we did lumbar puncture. We overall found no other disease, and her TTE was very positive for PFO. But I'll just mention that this is one of those cases where she was heavily sedated during the TE and could not produce a good Valsalva. So again, our imaging shown here, two areas of stroke that are deep. These are not the classic cortical embolic appearing, but in the right patient, one really has to have a high index of suspicion. So it's really about that pre-test probability. Why would this patient have small, deep strokes at age 23 without risk factors? And understanding that we need to look carefully for uh, stroke etiologies of PFO in those patients. And she, in fact, did have a PFO, and it was closed.
So that's certainly a patient in the upper end of the spectrum here.
Right.
So again, if you apply the rope score here, her young age and no comorbidity will give her very high chance to it's a PFO related or associated stroke here in this patient.
Yeah, I think if just off the top of my head, it would be about a 9, and she would
9.
score like an 88% likelihood that the PFO. So clearly more likely than anything else. And still, it's important to do the workup for things like multiple sclerosis and other things that can affect young women. But
Mm.
once they're negative, you really do have to understand that. Especially in the setting of retinal ischemic events, this is a woman who probably has some clotting on top of her heart issue.
Mm.
There's a few questions about atrial fibrillation in relation to PFO closure. Before we address them, maybe we should ask you, Dave, to talk about PFO closure, or PFO and atrial fibrillation.
Sure. Yes. I mean, it's always a topic of interest in relation to PFO closure. So, if we look at the incidence of atrial fibrillation, of course, in these patients, it's generally very low. And one of the questions people ask is, if a young patient has had a stroke, should we be looking for atrial fibrillation as a potential cause? And if so, how should it be done? Should you just do a routine ECG? Should you maybe do a 24-hour monitor? Should you possibly even do an implantable loop recorder? And some of these have become increasingly introduced into the guidelines. Now, I'm going to present a personal view and thought process on this rather than the guideline view. Some of the data comes back from the Crystal AF trial 2014. This was looking for patients with cryptogenic stroke of a rather older age group than those seen in the reduced trial, and not patients with a PFO necessarily. In fact, only 20% of them, so ordinary population, had a PFO, and they looked for implantable loop recorder evidence of atrial fibrillation. And this study was funded by the makers of the implantable loop recorder. You only had to have 30 seconds of AF in 6 months to be scored as positive, and the actual mean duration of AF per day amongst those who had any atrial fibrillation was only 4 minutes. So if you exclude the cryptogenic stroke from this, this is never a population who would even warrant anticoagulation under any circumstances at the age at which they were having these experiences. So this was an extraordinarily low burden of atrial fibrillation, and yet raised the question, should we be looking for this in everybody? And I think if you take an analogy here, if somebody has ischemic heart disease rather than a stroke, and they have, say, hypertension, and they have hypercholesterolemia, and they have impaired glucose metabolism, you don't say to them, we're going to ignore the hypertension because that's not important, because actually you've got raised cholesterol. And so by the same token, why would we ignore the PFO, which may well be the culprit in patients just because they've had 30 seconds of atrial fibrillation? So I think there's an inconsistent logic at work here in terms of the decision to chase atrial fibrillation extensively in otherwise young and fit patients. And I don't really think that that's particularly sensible. For me, it should be much more directed screening, and you should individualize the decision. So, for example, if you have somebody who's aged 59, they have hypertension, they have diabetes, they have perhaps a little bit of diastolic dysfunction in their heart or a tiny bit enlarged left atrium, they're, of course, a good candidate to screen for atrial fibrillation, because could that have been responsible for their stroke? If, on the other hand, you have a young patient with a floppy septum, an aneurysmal septum, a resting shunt, a history of a Valsalva maneuver around the time of the stroke, possibly even a history of venous thrombus formation or cardiolipin antibodies, then of course these are patients in whom screening for AF is just not sensible. So I would suggest that it should be very much a case-by-case decision as to whether to screen and how hard to screen. Now, in terms of the atrial fibrillation itself, that can occur post-procedure, this is something of a nuisance, and we always have to warn patients, okay, there is a risk. It's probably around maximum 5% that you might have one or more episodes of atrial fibrillation within the first 3 months after the procedure. Of course, it depends how hard you look as to whether you find it. Clinical experience is that it nearly always settles within 3 months. Sometimes you might need to treat it, give somebody a small dose of a beta blocker or possibly flecainide. It's very rare to require anything more than that, very rare for it not to be self-terminating atrial fibrillation. And I think you should manage it actively. I was interested in the 5-year results of REDUCE that actually there were 2 or maybe 3 patients in whom the AF occurred really quite early, but then persisted for a long time, suggesting that perhaps it wasn't actively managed, because really all these patients should go back into sinus rhythm. In terms of the post-implantation rates of atrial fibrillation, there's no material difference between the devices. They all have a slight propensity to provoke atrial fibrillation, and possibly in the very long term, presence of an occluder is a small risk factor for longer term development of atrial fibrillation. It would stand to reason that that could be the case. The ideal PFO occluder, of course, wouldn't have anything more than a background instance of atrial fibrillation, but really the ideal PFO occluder is still a mythical beast, which we don't have available to us. So I think that's a discussion of my take on the approach to atrial fibrillation. I don't know, Lars and John, whether you would have different views on that.
So, John, you as a neurologist is often the gatekeeper for sending patients to PFO closure. So, how is you doing this workup for atrial fibrillation, and what is your threshold for how should I say, denying the patient to have a PFO closure?
Yeah, well, I think that I always say that we're the most, stroke neurologists are the most paranoid people in the hospital. We think AF is everywhere. So there are a number of different strategies. I think that what Dave outlined in terms of risk factors is the key. If you look at that difference between the reduced patient that was average age 45 and the crystal AF and now stroke AF, I'll point out there's one other study that just came out last week in known causes of stroke. This is a patient who may have a carotid stenosis or a definite small vessel disease. There is a background of AF in stroke patients, and that regardless of whether they're cryptogenic or not. And what I think as neurologists is that there may be some autonomic dysfunction that occurs with a stroke, that you may develop some cerebral cardiac axis dysfunction that puts you at some risk even in the long term, that has nothing to do with the cause of the stroke. So how do we do that? We don't know yet. We're still figuring it out, what the right approach is. Some favor the hospital evaluation, which is maybe 2 to 3 days of telemetry. Others like to do this 2 weeks of monitoring and then wait 6 months and do another 2 weeks. Personally, we've gone with about a 1-month monitor on the front end for low risk patients. And we only use the implantable loop recorders in the high risk patients, those patients in whom we think they have a sick heart, they have a left atrial enlargement, something that would predispose them to AFib separate from their stroke.
But if a 1-month duration of analysis throws up somebody with 30 seconds of AF, what will you do then if they're age 40 but otherwise have a good indication for PFO closure? Will you say you've had 30 seconds of AF, you don't now qualify?
Well, I wouldn't say that they don't qualify. I would say that they need to just consider, that their medical management, their monitoring, and the fact that they may end up on both anticoagulation and PFO closure. We have certainly had a few where we felt like both. And the other question I'll put back to you all, because this is something that I don't know the answer to, which is just, do we know in patients with PFO whether that alone predisposes them to AF, regardless of device, whether there's been any true sample of that population? My suspicion is, that I don't know, I'm just a neurologist, but that there may be separate from the non-PFO patients, some risk there.
Yeah,
Tricky.
I cannot answer that.
But of course, in the medical arm of Reduce, where everyone did have a PFO, the incidence in the medical arm was very low, wasn't it? So
Yeah. So it seems that, of course, we need to exclude significant atrial fibrillation prior to the procedure, to accepting the patient for it. We can discuss how long the monitoring should be and also what's the threshold for denying it. But as you said, Dave, it's probably also worth to look into what kind of patient it is. If there's patient who are unlikely to have other causes, maybe the threshold for the length of the atrial fibrillation should be higher than another patient. Dave, there's also concern about atrial fibrillation post-procedure, as you said, and you mentioned up to about 5% of these patients had atrial fibrillation, and also of some concern. Some of these patients have silent atrial fibrillation; they don't feel anything. So how should we actually look at these patients? Should we do routine monitoring of these patients after to discover if they went into atrial fibrillation after device closure and bring them back to sinus rhythm, or how do you see that?
I think that would be a little harsh. I mean, monitoring people long term is not that much fun for them. I would not favor that. I think if studies suggest to us that a lot of patients have silent atrial fibrillation, and I don't think that's a significant population in the PFO cases, because most of the patients post PFO closure, if they go into AF, they go into classic rapid AF, which they will feel and notice. They're not a silent bunch in general. So I think those are patients who, by and large, come to clinical attention. In a clinical study, fine, monitor people and work out what the incidence of AF is that people didn't notice. I would suspect it's really rather small in this population. So certainly we don't go looking for atrial fibrillation in these patients post-closure.
So if you use a classical CHA2DS2-VASc score on these patients, they'll come out very low. They shouldn't have any anticoagulation. But how would you treat these patients? Patient coming back a week after PFO closure with atrial fibrillation, should you be aggressive, put them on anticoagulation, try to bring them back as soon as possible, or how would you do that?
Well, personally, I wouldn't put them on anticoagulation, and I would try and get them out of atrial fibrillation quickly with medical therapy, so beta blocker or flecainide, for example. I mean, if you take out their initial index stroke, which we're assuming was related to PFO and not related to atherosclerosis, the CHA2DS2-VASc score is sort of not really as relevant anymore. They should have young, healthy, low-risk left atrial anatomy and physiology. So I wouldn't usually put them on anticoagulation. It's really a very small proportion who get atrial fibrillation and then remain in it for any duration of time. They normally have a paroxysm of AF. And so then you say, okay, fine. Well, for the next 2 months, let's give you a small dose of beta blocker to try and keep that away until it naturally resolves of its own accord.
I will just add that in both the crystal AF and the stroke AF studies, so both of these devices that were detecting AF, many patients were anticoagulated in the device arm. And of course, the patients who weren't in the device arm, they weren't being detected and they weren't being anticoagulated. As far as incidences of strokes, they've yet to demonstrate that actually reduced the incidence of stroke by detecting and anticoagulating. Over time, we may see that, but to your point, an otherwise healthy heart may not benefit as much from anticoagulation for stroke prevention.
So Dave, let's move on. Yeah, I think you got a case which is also outside the IFU for PFO closure. We can discuss.
Yes, I mean, it was just a question really of moving outside the guidelines, and there are a number of areas where the guidelines don't really cover at the moment. We've partially alluded to this already, but let's say we have a 65 or 66-year-old patient outside the American guidelines with no risk factors, who's had a stroke affecting, say, face and speech with good recovery. They've had the routine investigations, which in the UK are not that extensive, I think, as in some other countries, but they would have had a carotid ultrasound, and let's say that was normal, and they've had ECG or some monitoring, which is normal, and a structurally normal heart other than a PFO, would people feel comfortable that they should be referred for PFO closure? I mean, I certainly would, and we would be very happy to take that sort of patient on, assuming that the neurologists or stroke physicians have looked at them and said, we think the PFO is relevant from our point of view. What would happen in Copenhagen, Lars, for this kind of patient?
Yeah, again, this is a good. I think we don't, as I said before, I as a cardiologist is not the gatekeeper. I would leave it to the stroke neurologist to decide who should be offered a PFO closure and who should not. I think I'm a little bit concerned as you, as the interventionist, is actually setting the indication for it. But I think as the patient you just presented could very likely come forward for a PFO closure.
Yes, I mean, that for me is the key, that it's, and sometimes the people who are paying for this haven't quite grasped that, as you rightly say, the cardiologist is really functioning purely as a technician in this scenario. The neurologist or stroke physician does the workup, presents a patient that they believe is suitable to the cardiologist, who 9 times out of 10 will probably agree and say, yes, that's fine. But so it's important to have more than one discipline involved. Otherwise, you could have a scenario where cardiologist goes around the hospital finding PFOs and closing them unnecessarily.
Yeah. Yeah, I would say in my work with our team, I think that the patients need to hear the efficacy and diagnosis from the neurology side, and they need to hear the safety and cardiac anatomy discussion from the cardiologist, and then the patient themselves needs to think about it. These guidelines are and reasonable and rational, but everyone's individual, and they should be able to kind of think about it. We've avoided doing in-hospital, same day, same admission as their stroke event, to give them that time to think about this. And I think that's what I would advocate is for them to hear from us, hear from you all, and then think about it.
Dave, there's one more question about the atrial fibrillation. There's one asking, what is the reason for atrial fibrillation after PFO closure?
I mean, I don't know. I assume it's simply the irritation and inflammation and structural abnormalities. Of course, we think atrial fibrillation starts in the pulmonary vein, so we're nowhere near that. Why have we produced atrial fibrillation? I guess it's simply just the structural change and the inflammation that it creates. What do you think?
Yeah, that's also the simple mechanistic explanation I would have. You have the device, which in the beginning may scratch a little bit on the septum and trigger it, but it's hard to say what it is. Again, it's after PFO closure, it's within the first days, within the first weeks afterwards, and I think when it's overgrown with the endothelium, I think the likelihood is very small that you're going to see it.
Yeah.
So I think it's a mechanical triggered arrhythmia.
Yeah.
There's also a question about the shunt after PFO closure. Is because also in the trials we're talking about the PFO was closed, but actually it's separated between, how should I say, complete closure and effective closure. And I think for all trials, the complete closure was only seen, as I recall it, in around 75% of the patient, 3 out of 4 patients, where you have effective closure was in 95% of the patients. What is effective closure? It's hard to say. I think some of the trials used that during a Valsalva maneuver and a bubble contrast injection, you could not see more when, I remember, was it 25 bubbles coming across? Where that threshold came from, I don't know.
It came from people who wanted the number to be better. But I mean, to be fair, actually, it does make sense, because the bubble test is always only a surrogate for what you're actually trying to do. What you're actually trying to do is stop a clot going from right atrium through the PFO to left atrium to the brain. A bubble is an incredibly lubricious, compressible devious little thing which can squeak its way around multiple corners and end up in the left atrium. So I think, it's fundamentally kind of reasonable to suggest that a bubble passage of a few sneaky bubbles that manage to get there is not the same as clot resistance. The physical barrier of the PFO closure doesn't have to be completely bubble tight to represent a barrier that's clinically effective to clot. I think that's how I kind of think of it. Maybe wishful thinking on my part, but
But that's how the trial was actually designed. So just keep that in mind. And also, I think all the trials also show that as time is going by, up to 1 year, you have more and more closure of these defects. So
Yeah.
it will take some time before you have endothelium overgrowth.
Yeah, in the 5-year data, there was increased closure by 5 years.
Yeah. Yeah. So now we have discussed quite a lot about PFO closure in these, how should I say, at least selected patient suffering from a cryptogenic stroke. But there's also other indication for PFO closure. And Dave, maybe you can just try to give us an overview when PFO closure is actually offered to some of these patients.
Sure. I mean, there's a host of other scenarios where a PFO may be important or implicated in someone's clinical presentation. When a tiny clot goes through the PFO, it doesn't have to end up in the brain. Sometimes it ends up somewhere which you don't even know about it. But of course, if it goes down the coronary artery, you probably will end up knowing about it. So a small proportion of cases have embolic myocardial infarction without underlying coronary artery disease. And these will sometimes present as cases for PFO closure. And I'd be interested to hear, Lars, what you think about them. Of course, there are patients with decompression sickness. Now, some of those are recreational divers, but some of them are occupational. And, if you don't close the PFO, they lose their occupation. So are they catered for in the guidelines? Then, of course, there's the patients with, for example, platypnea orthodeoxia syndrome. It's rare. It's incredibly gratifying to fix. The patients turn from blue to pink and are utterly delighted with the procedure very quickly. And then, of course, there's migraine as well, which there's been a 15-year history now of investigating how we can suitably close PFO effectively to reduce migraine. So I think, from myocardial infarction, from my point of view, you can consider it on an individual case basis. For divers, as I've said, I think the occupational aspect is key. Platypnea orthodeoxia is a no-brainer. And then the migraine is it's a long-running sore, frankly, for which there have been a number of trials. Some ended up in unnecessary controversy, but all have given evidence at least towards the direction of migraine benefit rather than away from the direction of migraine benefit. So I think there's still something to be looked at there. And I'd be interested to hear what John, for example, has to say about that, because, of course, there is another migraine study coming now.
Yeah, I think that when we look at the story we had with stroke prevention, it started with negative trials. And it started with negative trials because of at least in part because of patient selection, not choosing the patients who would benefit early on, and over time determining what the right medical management and the right patient selection and the right criteria for following those patients. So I think we're beginning to see that with migraine. The concept is that there may be something, migraines are really triggered. They're triggered by a neurological event, and then they spread and become a syndrome over days. So is it possible that the trigger is something cardiogenic? And if so, how can we detect that? So the RELIEF trial, which is a trial from Gore looking at patients with migraine in the U.S. This is a relatively small trial. 150 patients will be enrolled starting in April, and they're selecting using their response to clopidogrel. So the concept, if these patients who respond to clopidogrel in other retrospective studies have been the ones who benefit from PFO closure. And now that we have a device that we have a safety record with, that can be used. The only other comment I'll make about migraine is, I've had the opportunity to be in migraine PFO studies and stroke PFO studies. I will tell you it takes an hour or more to discuss stroke prevention and PFO with a stroke patient, and they really need to understand the risks and benefits. The amount of disability, the amount of discomfort, the amount of lifestyle effect that migraine has on patients, it takes about 5 minutes to talk these patients into doing something different from what they're already doing. It is the number one cause of disability in the working age population.
So John, just to continue this discussion on the migraine, how actually to make sure that it's effective? I mean, one of the beautiful part of the REDUCE trial is that there was this brain imaging part of it. So all patients have an MRI scan of the brain prior to the procedure at the inclusion time, and also after 2 years and early on if they have an event. So you can actually quantify whether there was new lesions in the two groups. What is a meaningful endpoint in a migraine trial?
That's a great question. So the primary endpoint in the RELIEF trial is the reduction of basically headache days per month. So if you go from, there are 4 categories of how many, how severe, how many days you're having per month. And if you change category, that counts as a benefit. But to get to the hypothesis, there are secondary endpoints looking at platelet responsiveness and whether this, independent of the medical management, whether the PFO closure reduces the patient's platelet responsiveness. So that's how we look at it. But I would also say that it's a highly scientifically rigorous study. When you look at the placebo effect for anything that involves pain, one has to account for that in a study. So to account for that in the other studies, and again in RELIEF, there's a sham procedure. So the patients would come to the cath lab and receive a theater that puts on, the concept that you're getting something done, and then they leave and they would not know whether they received it. So the investigator that on the neurology side is blinded as well. The patient is blinded with a sham, and they would be followed with a headache diary.
So we have
delighted that there's another study going. I'm absolutely delighted there's another study going for migraine, because it was all mired in unnecessary controversy, and I'm delighted to hear that the patients are again really keen to get involved in the study, because I think actually there is a subgroup definitely who benefit, and actually we did see this in previous studies, MIST, PRIMA. So I'm really pleased. I think there will be a subgroup who we can identify, hopefully with migraine and aura, but you may close it down more than that, who can benefit substantially. And of course, as you rightly say, it's a massive cause of disability. So this could offer a good therapeutic option for some of these patients.
Absolutely.
So Dave, what do you see as a big difference with this trial compared to the MIST trial, and why
can I say
this trial have a better chance
one of the chief investigators is different? I mean, honestly, the problem with the MIST trial was a really well-run trial that recruited in record time. And unfortunately, everybody was disappointed that the primary endpoint was negative. But then instead of that being hypothesis driving and resulting in general discussion, it disintegrated into a controversy between investigator and company, and that was very, very unfortunate. I think, hopefully the inclusion criteria of this trial will be slightly more focused. They'll probably take patients that have got migraine with aura. They'll probably take patients with a sizable shunt. They'll probably take patients who are only clopidogrel responsive, and this may focus down the patient group to be able to demonstrate a positive benefit.
Yeah, I will just follow up on what you said about the shunt size. It was interesting as we've done these stroke trials. We've seen the whole spectrum of shunt size. We certainly see stroke patients with small and medium shunts, and probably as frequently as we see the high shunts. But when it came to the migraine studies, they were all high grade shunts. So one is just struck by that difference in patient population, and whether there's a different pathophysiology of admixture going on here with those patients.
Yes. Yes, interesting.
So I think we reach getting closer to the end of this webinar. We have a good discussion. There's a few questions back here. Maybe we can address it. One is about the safety of PFO closure. We talked about new onset of atrial fibrillation, but there's other risk factors, Dave, for people who wants to refer patients about the procedure itself.
Yes, I mean, there are some PFO closure, but they are rare than vascular injury that you need to use. So you need to use ultrasound guidance to make sure that your access is safe. Tamponade is theoretically possible. Device embolization is theoretically possible. But really, in experienced hands, these should be really rare. I mean, it should be 1 in 3 to 500 having a major complication.
So it is a pretty safe procedure. John, there's also a question here about, we were talking about atrial fibrillation before accepting patient for PFO closure, but also afterwards. And there's a question here, can you use a smartwatch to monitoring AFib in these patients?
I think that's exactly right. When Dr. Hillick-Smith made reference to the cumbersome and uncomfortable and how patients don't like to feel sick and wear monitors and things like that. I hear that loud and clear from our patients. In fact, there's probably nothing that's more upsetting to them than wearing heart monitors. But many of them are willing to have a smartwatch, and the detection algorithms are getting better. I don't know. Again, I'm not an electrophysiologist. I don't know how competent the devices are, but it seems like a way forward for monitoring that's less invasive.
So I think we again approaching the end of this this webinar. I think we had some good discussion about where we are now. That's happening a lot since 2017. I think the guidelines has been changed in most countries. The awareness about PFO closure has increased. We see patients coming forward. For those of us who's doing this procedure know it's a very safe procedure. The risk of having a procedure complication is really low in experienced sites. And again, it has a huge impact, at least on preventing recurrent stroke in selected patients. I think we also have a discussion led by you, John, that we should maybe not be so strict looking at the guidelines, but look at each individual patient. The rope score can be a useful tool to try to see whether patients have a high likelihood to have a PFO-associated stroke and also will benefit from this procedure. So don't be too strict in your patient selection according to what the trials and the guidelines are, but look more on each individual patients. And then finally, we had the discussion on migraine. I think that's going to be really interesting to see whether we can finally see a well-conducted trial to try to solve this major questions, which there are a lot of patients who potentially could benefit from. John, any final words from you?
Just to go back to what we discussed earlier, that the magnitude of benefit for secondary stroke prevention here is substantial, and really the most benefit for these patients in this category.
And you, Dave?
Yeah, no, I think PFO closure is an extremely safe and extremely effective procedure. And I think gradually over the course of the next decade, it will become an extremely commonly undertaken procedure, which should continue to be guided by a multidisciplinary approach rather than individual disciplines.
So with that, I want to thank you, John and Dave, for doing this webinar with me. I think it was good fun for this hour. I want to thank all you who have been watching it. I want to thank PCR and WL Gore for organizing it. So hopefully see you all soon in person. Thank you a lot.
It's a pleasure. Thank you.
Bye-bye.